very good morning. How are you doing? I hope that you're having a beautiful Wednesday and that everything is going on okay. And even if you're not, I want to encourage you that the day gets better. So I hope all is well. Now today is Wednesday. Wednesday we like to talk about matters health. And today we want to talk about something that is plaguing a lot of people. In fact, it is about 5,236 women who are diagnosed about every year, and 303,211 are said to die from cervical cancer. However, there is a vaccine. And to put this into more perspective, and I'm sure you'll have many more questions, and even just hearing that might be shocking, that what is a vaccine? Maybe you didn't know. To put this more in perspective, we have a guest here. I'll allow him to introduce himself.
Thank you very much, Willis, for welcoming me to the studio. Yes. My name is Dr. Kireki Omanwa. I'm a consultant obstetrician and gynecologist, and also a fertility specialist. And then apart from that, I'm the president of the Kenyan Obstetrical and Gynecological Society. All right. Yes.
All right, well.
I'm happy to.
So we can call you Mr. President.
Oh, well.
All right. On a lighter note, Daktari here supports Arsenal, but I feel he has been, because there are more Arsenal supporters in this room, he might have been
indoctrinated.
Yes. But it's okay. Well and good. We support you despite your choices. All right. So, Daktari, of course,
yes.
Whenever people walk into any hospital and they hear, cancer.
Yes.
And nobody ever wants to get that report.
Absolutely.
It's sort of has been painted, and even just by the numbers, as doom and gloom. Absolutely. So maybe we can start by, especially since it's cervical cancer, maybe you can help us to understand what it is.
Okay.
Yes.
Maybe I'll start by just talking generally about cancer.
Right.
In the last 8 years or so, from 2012 to around 2020, we have seen a systematic increase in the cases of cancer. And annually, this is from the Ministry of Health, we have about 42,000, slightly over 42,000 cases of cancer every year. Wow. And the leading cause of cancer, or the cancer that is leading in these causes, is breast cancer at number 1, at about slightly over 6,000 new cases every year. Wow. Then we have cervical cancer, which is about 5,200, 5,300 cases every year. Then we have prostate cancer at about 3,400, esophagus cancer, and then we have colorectal cancer. And then we have all other cancers, cancer of the blood, cancer of the bones, etc., etc.
Right.
Now, out of these 42,000 or so cancer cases every year, when it comes to the death rates, the highest killer is actually cervical cancer, at about 3,200 cases every year, followed by breast cancer at about 3,107 every year. And then esophagus cancer comes third, about 2,700, sorry. Then colorectal cancer, then prostate, then stomach cancer, then leukemia, and then other cancers altogether. Now, we have this perception that once somebody has been diagnosed with cancer, that is the end of it. And then there is also, the grapevine which says, ati alienda hospitalini, akaambiwa yuko na cancer,
right,
akapelekwa theater, akakufa.
Right, yes.
Usually this is a misconception, especially when it comes to cervical cancer. Right. First of all, many people don't know about cervical cancer, and that is why January was a cervical cancer month.
Right.
And I think this is a very good opportunity, and thank you very much for allowing me to come here and talk about cervical cancer,
right,
because it is the leading killer of women in this country.
Why do you think, is it because of the, I don't know what term to use, is it, let me say, the intensity of it in terms of the way it multiplies, for example, or is it because people don't have information, or why is that?
I think number one, there is no proper information.
Okay.
And then number two, usually it is discovered very late because it is quote-unquote acquired killer, there are usually no symptoms at all. But before we even go to the symptoms and you know what it is and how it can be treated, maybe the causes of cervical cancer. Right. Possible causes, number one is multiple sexual partners. So if you have multiple sexual partners, there is a very high chance that you will have, a lady will have cervical cancer. If she decides that she's going to be, you know, she's going to have only one partner, but this partner has several partners out there, so there is a chance that this partner can actually bring HPV virus, which is the cause of cervical cancer, to this lady who has decided that she's going to be completely monogamous, as it were. Early debut in sexual intercourse, because most of the time, if a young lady decides to have intercourse and let's say at around 15, 16 or 17 or whatever time, highly unlikely that he will stick with this one person. Right. So, and then you saw the statistics which came out the other day. Right. That men, we are doing very well in that we have at least 7.1 partners. Right. In a lifetime. Stellar performance. Right. And then the ladies have, you know, 2.4. So there is a sort of a disparity here.
And then also beyond that, they're starting, I mean, they're engaging in sex early, from 15.
That is true. Right. But then the statistics should have also been sort of, you know, almost the same. Because if gentlemen are having an average of 7.1 and ladies are having an average of 2.4, there's a difference here, which we don't know how to account for. Right. Most probably is that women want to talk about the mountains we have conquered, and the ladies want to sort of tone it down.
Put it under wraps. And I had this argument with somebody online, actually. And I was telling them the same thing. Because it's a survey. You can as well, as a woman, you're not going to tell your business. Anyway.
So if you start early and you have many sexual partners, this is, you know, this is a probable cause for cervical cancer. Right. Deliveries, you know, our women have always had many children in the past, and they have had them over a short period of time. So it is postulated that the micro injuries that happen during a delivery can later on be a basis of cervical cancer. Obviously, this is just a base. There can be other things which can sort of hook onto these micro injuries. We talk about sexually transmitted infections, where chlamydia is one of them. And chlamydia, by the way, is also a silent quote-unquote killer, because it affects women. It has no symptoms at all. It leads to blockage of tubes and so on and so forth. And then by just the infection of chlamydia and maybe even herpes, the HPV virus can very easily hook on to these infections and then start its progression, as it were. And then after maybe 15, 20 years, this lady will have cervical cancer. We talk about the immune system. Right. The immune system is basically what protects the body against bacteria, against viruses, and so on. So if the immune system is not working optimally, then of course any other infection can jump on, and HPV is one of them, which will hook on and will get, you know, will progress to cervical cancer. We see a problem with ladies who have HIV. Right. We find that when they are infected with HPV, the cervical cancer is sort of more aggressive, and then these are usually very young ladies. We see them in Kenyatta, where you have a lady who is maybe in the 20s, 20, 25, 27, with stage 3, stage 4 cervical cancer, which means it has spread to other organs, it has spread to the bladder, it has spread, you know, to the rectum, and so on, where it's very, very difficult to treat. However, there are also other cases whereby the immune system can be compromised without it necessarily having been a disease. Right. For example, if a patient has had a transplant and this patient has to take medications to suppress the immune system in order for it to allow this foreign organ to continue, you know, serving her. Then also in such a case, if this lady has contacts HPV, then unfortunately the disease progresses a lot faster, cervical cancer. So these are some of the reasons. Obviously, they're not all exhaustive, but these are the most important reasons.
So for, I mean, so this is, does it affect men, first of all?
Cervical cancer, no, it does not affect me because you don't have a cervix.
Exactly, because I've seen somebody on Twitter asking about the vaccine. Can I get it if I'm a man?
Now, that is another thing. Now, even before we go to the vaccine and what we need to do in prophylaxis, I think there may be some of the things that our audience needs to know about is how to prevent it. How to prevent cervical cancer.
Okay.
Number one is obviously reduce the number of sexual partners, and hopefully that.
So this is sexual partners. Of course, we're assuming that people are going at it without the ABC, without the C.
Yes,
having unprotected sex.
Unprotected sex.
All right, gotcha.
Yes, that is right. And then that is number one. And then obviously number two, delay the debut of sexual intercourse. The later, the better. Obviously, there are some instances, or there are some fora whereby they say avoid intercourse. Be a virgin until marriage. Which is a noble idea. Sometimes it works. Sometimes it doesn't work. But then let us try and delay this debut. Even apart from cervical cancer only, there are also other issues which come with early debut. Look at what is happening with our young girls, adolescents, getting pregnant at 13, 14, 15, and a huge number of them, because what happens is that, number one, they drop out of school. Number two, they don't have any skills. Number three, they are bringing a baby while they are still children themselves. They have no means of taking care of these children, and so on. So they actually start a cycle of poverty, which even these children they have delivered may not actually be able to get out of it. So there are positives of, delaying this sexual debut, apart from, HPV infection. Now, it is suggested, and we as COGS, the Kenyan Obstetrical and Gynecological Society, we want our ladies to actually know about what cervical cancer is and how it can be diagnosed. And the diagnosis is simply by doing a test. It's a simple test called a pap smear. It is the most common. There are obviously other tests. It is the most common and most available. You can get it in every public hospital. What it basically entails, once we have taken the history of the patient and we have explained what we are going to do, we protect the patient's dignity and respect. We cover her and we ask her to lie on a couch. And then we take what is called a speculum, which can be metallic or sometimes can be plastic. I know some ladies may have been traumatized by using that instrument. And we explain what we are going to do. We take this equipment, line it, smear a little bit of gel so that it can be easy to insert it in the vagina. Because remember, the vagina is a very sensitive place. It has a lot of nerves, and then apart from that, it's an intimate place. Then we insert it gently and open it gently. We have to tell the patient all the time. Communication is very important, such that the patient knows what to expect. Because sometimes it can be that when you insert it without telling her what is happening, it's a reflex action. She can sort of, go into flex her, contract her muscles, then it becomes a problem. So we open it gently. We tell her she's going to feel a bit of pressure in the vagina and sometimes in the rectum, and we visualize the cervix. The cervix is basically the entry to the womb. If you can imagine a balloon. So when you're blowing on the balloon, the place where we blow the air into, that is what we call the external os, or the external opening of the cervix. Where the air goes through, we call it the canal. And where the air goes into now the balloon itself, we call it the internal os. So now once we have visualized the external os, we take a brush and we insert it gently and twist it very gently. You can do it 2 times or 3 times, 360 degrees. We get material from the cervix itself and also from the canal. That is usually where the problem is when it comes to cervical cancer. There's what we call the junctional zone. Now, we take this material and smear it on a glass. And then we fixate it usually with alcohol and send it off for analysis under a microscope. So the doctor who is analyzing this, what we call a histopathologist, will look and say, this smear or this material is okay, no problem.
So what are they looking at?
We are looking at cells.
Okay.
We are looking at cells. So they look, because the cells, you cannot see them, with the naked eye, but you can very easily see them under a microscope. So we look at the cells that we have collected, and they will say these cells are fine, no problem. Come back after 3 years. These cells these cells have some infection in them. Treat the infection, and then come back after the treatment of the infection. These cells look suspicious. By looking suspicious, what it basically means, the shape of the cells may have a problem. What we call the nucleus is basically the engine in the cell. Right. The nucleus may be too big in proportion to the cells. I mean, to the cell itself. You say this is abnormal. This needs to be checked. So once we receive that result, that this test is abnormal, we need to do another test, what is called colposcopy. And colposcopy is basically, again, analyzing, looking at that cervix. You remember we said, if you imagine this is a balloon, this outer space, we smear it with some chemicals, and then we have a look at it. If there are changes on this, where we have smeared the chemicals, then we take a little piece of that tissue, what we call a biopsy, and then it is also analyzed. Now, once we have looked at that, the histopathologist says, you know what, this is precancerous, for example. Before cancer. Okay. Before cancer. Okay. Meaning that we have caught this disease at a very early stage. Right. Now, this is very easy to treat. We can actually cut the area where we saw there was a problem with a margin. Very easily done. It's done in a day, and the patient goes home.
Right. So if you, just to understand it, because you said you pick just a small section of it.
We cut a tiny bit.
Right.
Yes.
So if you cut from this bit, it means, and it's infected, basically means the whole area is affected.
What? Yeah. Okay. Now, when we cut, because when the histopathologist or the doctor who looks at this piece will actually look and say, this is actually to a certain level, because there are different layers of cells. Okay. And this is basically just the upper layer of the cells. So we know that all the upper layers, what we want to do is want to get as much of that upper layer of cells with a good margin where there are healthy cells. Then we'll know that we have actually got rid of it. Okay? Now, you may say, you know what we have looked at, unfortunately, it has gone a little bit deeper. In the second layer, let's call it the second layer of cells. What do we need to do? Now we need to know, number one, what type of cancer it is, right, and of course how far it has infiltrated. The infiltration can be different. It can be less than 3 millimeters, about 3 millimeters, it has gone beyond 5 millimeters, and so on and so forth. Once we see how far it has infiltrated, now then we can decide on the type of treatment. Right. And the type of treatment can either be surgery or surgery as well as radiotherapy, where we use what you call ionizing energy to kill the cells which are there. Or sometimes it can be the surgery, radiotherapy, as well as chemotherapy, again depending on how advanced this cervical cancer is. Right. But you see, by the time we say we are going to do radiotherapy and we are going to do surgery, or we are just doing radiotherapy and chemotherapy only because the cancer is very advanced, then usually this is when the symptoms are there. And usually this is quite late. And the symptoms that patients will come with, number one, they will tell you, Daktari, I've been having some bleeding, which comes just like that. It has no relationship with the periods, and it comes in between the periods. Sometimes it's quite heavy. There is a smell that I have noticed, and that smell is horrible. It smells like dead meat, for example. I have noticed that I'm passing pus, through the vagina, and so on. So these are telltale signs that actually this cancer is already quite advanced. So the first thing that we need to do, obviously, as I said, we need to look at the cervix. But again, you remember the speculum that I talked about? We insert, we have a look. Sometimes when you just look, you can actually have a very high index of suspicion because it has grown, it is irregular. Sometimes you call it is cauliflower-like, or it's crater-like because it has eaten the cervix completely, and so on. And then we do a vaginal examination, an internal examination. Usually this is done in theater, such that we go and feel, we put the patient under sedation, and then we can examine. You can examine the cervix, we can examine the vagina, we can examine the bladder as well, and see how far it has gone. There are other tests as well which are very important. That is a scan. It can be an ultrasound scan. We can also do a CT scan, and sometimes we can do an MRI scan just to know whether it has spread, where it has reached, if what we call lymph nodes are also affected. And we also need sometimes to do a chest scan to see whether there is any spread to the lungs as well. And then now that is when we start talking about treatment. But by the time we get there, it's very late. We want ladies to come for the screening so that we can catch these issues when they are precancerous.
And this is every 3 years or every 1 year? Or
every 3 years. Now, there are different let's call it guidelines, depending on where you are. In some countries in Europe, they say come for a screen every year. And then if 3 of them in a row are okay, then every 3 years. Again, you see there are financial implications with this. So here we've taken a stance that at least even if you come once every 3 years, it is a very good step in the right direction.
From a certain age?
Yes. Now, the age is usually determined by when you started intercourse. So if you start early, then we want to start screening early. But by and large, we want to start screening around the 20s. In the UK, for example, they say you start around 26. They started arbitrarily. There is no real science which says 26. Maybe there are other economic, issues which are connected with that. That is one. 2, once we have these, let's say 2 or 3 of them are okay, every 3 years and the results are fine, then we can do it every 5 years. Then we assume that everything is okay. Remember, before this cancer manifests itself, it has lived in the body, stayed in the HPV, has stayed in the cells, changed them over a long period of time, usually about 15, 20 years. Yes. Now, there is also another way of checking for cancer, and that is by checking for the HPV virus itself. And there are cases, actually there are some studies which have been done in South America, that there is an equipment which the ladies can actually buy, and they actually do the testing themselves at home. They insert it inside the vagina because they are the ones who know, they feel where the cervix is. And if they've been traumatized in the past, and remember these are very intimate and sometimes, it can be a bit embarrassing as well. So they can do it at home, collect the cells in that equipment, put it in a bottle, and then send it obviously with a preservative, and send it to the lab for analysis. The only hitch about this can be the cost factor. Yes.
All right. So we want to, of course, ask also if you have any questions. And this is a question we're asking you. What questions do you have around cervical cancer, or if you have any other, questions around it as well? What questions do you have around cervical cancer? That's the question. Now to SMS, the line is 22422. That's our SMS line. Is open. Now, because this might be a little bit intimate and requires you to be a bit vulnerable, for the SMS platform, you don't have to leave your name, you don't have to leave your name. We'll hide it, and then you can go ahead and ask your question. Just send the SMS, and we'll only show the SMS. But if again you feel bold enough, you want to share, comment, you can go ahead and use, say your name and where you're watching from. So it's 22422, that is SMS 22422, and then the hashtag to use if you're on the internet, it is Daybreak. Again, I remind you that if you're on Twitter and you use your handle, unless it's a pseudo, the question will be, your handle will be shown. So in case you want some privacy, it's better to use the SMS, which is 22422. All right, so Doc, now there is the issue of the vaccine, but you've talked about the HPV, right?
Yes.
So what type of virus is HPV? And somebody may ask, how is it then transmitted?
Transmitted.
Yes.
Very good, and thank you very much for that question. HPV is a group of viruses called human papillomaviruses, and there are over 150 of them, or subgroups of them, and they cause all manner of things. They cause, skin warts, they cause plantar warts, for example, on the leg, sometimes on the knee. They can cause also other types of cancers, for example, vulval cancers, penile cancers, perineal cancers as well. But now the focus here is on cervical cancer, and cervical cancer is basically caused by two very virulent groups, subgroups, I may say. That is subgroup number 16 and subgroup number 18. However, there are other, we can call supporters or adjuncts, which can also lead to this, subgroup number 6, number 11, and others, they have added, 35, 42, 52, and so on. Now, what the human papillomavirus does, once it gets into the cells, here we are talking about the cervix, it gets there and it sort of, quote unquote, takes over the normal functioning of the cells. It stops the cell from doing some certain things. For example, the cell cannot die once it has reached its date of, its date of death. It stops it from dying. And then it starts producing some other protein, which helps this HPV to continue growing. And then by doing this over a long period of time, of course, it disorganizes completely the functioning of the cells in the cervix, and then starts changing them into precancerous. And then after that, there is cancer, which is non-invasive. Then it gets into invasive cancer. Now, when we talk about a vaccine is basically something that is supposed to protect us from either a virus or even bacteria. Remember, when you have children, we take them for vaccination. Take them for vaccination against, hepatitis, against measles, for example, and so on. Now, there are different types of vaccines. Sometimes we have the causative agent, whether it is a virus or a bacteria, which has been reduced, the virulence has been reduced. So when it gets into the body, what happens is that the body recognizes, the immune system recognizes that this is what? This is an enemy. So it produces what we call antibodies. So the next time the body will come into contact with actually the real causative agent itself, it has what is called memory. So it will remember that we have seen something like this before, so it will send the soldiers, what we call the antibodies, to go and stop this enemy. So essentially that is what we are doing, or that is the basic principle when you talk about vaccination. There is that memory, and that is why once you get a vaccine, especially in children's diseases, you find you have a lifetime protection. Now, the same with HPV virus. It is suggested that young ladies who have not started having intercourse, be around 12, 13, and onwards, are the ones who are basically the basic target. Why? Because then they have this protection. And by the way, sometimes the women can have all these HPV infection, but then the immune system that I talked about will clear these viruses. The only thing is that if the immune system is not strong enough, as it were, that is when now the 16, 18, hang on to the cells and change them. There is a WHO strategy from 2018, and they call it the 90-70-90 strategy. And the 90-70-90. Yes, because WHO came and started and said, look, we have a lot of problems with cervical cancer, especially in the developing countries. So what strategy is it that we can put in place so that it can sort of help in the future, downstream, as it were? So the first 90 is basically a target to vaccinate 90% of 15-year-old girls.
So you're starting at I mean, because that is the average age now.
As the average
they're
age,
becoming sexually active.
So remember that the HPV virus takes about 15, 20 years before we actually see the effects, the cervical cancer. So hopefully by having a target of vaccinating 90%, we will reduce the incident rate by about 90%.
Okay.
Now, the 70% in the middle is basically to screen ladies who are 35, at least 35 years. So at least let them come for, for the screening, for the pap smear. And if you can also be able to do HPV, the better. I got information the other day that the Minister of Health had actually, together with one of the partners, actually now that the HPV testing should be available or will be available in government offices, government hospitals, which is a fantastic step in the right direction, because this again will go into maybe complementing what the WHO strategy of the 90-70-90. Right. Now, the last 90 is basically seeing the patients who have been screened and have pre-cancer, so that it will be treated properly. And then if there is invasive cancer, they have also been treated as per the protocols. So the 90-70-90 strategy.
So then there is there's a small problem there, I think, and maybe you can correct me if I'm wrong, because now, so how do you explain to the 15-year-old that we are taking you to get this vaccine?
Yes.
That's number one, because again, it's a conversation that has come up a lot of times about sexual education. And
absolutely.
Yes. And then number two, is it like, now the vaccine that's in most people's memory is the COVID vaccines. So is it one time? Is there a booster? Is it 2 doses? Yes.
Yes. Now that is a very good question and a very good observation. There was a pilot study which was done in this country in a few counties, and basically it was to look at how the rollout is going to be.
Right.
And the reception was quite good, even though we would have expected it to be a lot better. Okay. Now the rollout, the first 90 that we are talking about, and how does Kenya as a country sort of tag into this and roll out this vaccination. There is a special unit in the Ministry of Health, and this is called vaccines, I think. And there is a lady there, a friend of mine, Dr. Mecca, who is actually in charge of this vaccination. First of all, the vaccine is free of charge in schools. So basically the target is to roll it out in schools such that when these girls are in school, they are supposed to get this vaccine. Obviously, we cannot give this vaccine without consent of the parents. Now, that brings in now the question of what you asked and what is in most parents' minds, that if we are going to give this vaccine, so does it mean that we are giving these girls a go-ahead, to start being promiscuous? Nothing is further from the truth. This is basically prevention. And sexual promiscuity, unfortunately, it is something which is happening, and giving a vaccine does not open the gates, as it were. This is just a preventive strategy. Obviously, nobody is going to be forced to take the vaccine, but we encourage the parents to actually encourage their daughters to have this vaccine, to have them vaccinated. This has not only been in Kenya, where this problem of stigma and if we do this, what is going to happen to our girls and so on. Even in some other countries, in Australia, some states in the US, for example, in Texas, they also had this same challenge that we are having. But again, I think it is an issue of education, knowledge, because as the Bible says, where there is no knowledge, unfortunately, people perish. And we are perishing. 3,211 women die every year. You know what it boils down to? It boils down to 9 women dying every day. So every day somewhere, there are 9 families who have lost a wife. There are 9 gentlemen who have lost a wife. There are in 9 families, some children have lost a mother. So every day there are 9 families where sisters have lost a sister, or they've lost an auntie, they've lost a grandmother, and so on and so forth. So when we look at it that way, maybe we look at it a little bit differently.
Right.
And you see, as the old adage says, prevention is always better than cure. Treating stage 3, stage 4 cervical cancer is very expensive. Apart from the radiation, there are other adjuncts which come into place. Right. For example, you find most of these patients come and they have a very low HB, meaning they have been bleeding profusely. So the body, the amount of blood, let's call it that, the amount of blood has actually reduced. So in order for us to be able to treat them, first of all, we have to transfuse blood into them so that this blood can be able to actually take that medication to where it's supposed to be. Right. This is days in hospital, and sometimes you have a challenge in actually getting blood. You may need 5 units, you get 1 unit, meaning that this patient has to be in hospital all the time until she gets, first of all, she is ready for the chemotherapy and the radiotherapy. Sometimes it has affected the kidneys and the tubes that pass urine into the bladder. So sometimes you have to do procedures where the urine is diverted. Now, that is an extra cost. Now, not even factoring in the cost of the medication itself, the psychological, burden for the patient, for the family, and so on and so forth. So I come back to what we are insisting on as a society, the Kenyan Obstetrical and Gynecological Society. Prevention is better than cure. So let these ladies go out, let our ladies go out and have them checked so that we can be able to prevent these 9 deaths every day.
Very, very, if you put it like that, I guess it kind of brings it home, closer home. We'll take some questions, and of course I'll still ask the question about the vaccine, but let's take a look at what some of you are asking as well, so we can ask Dr. here. Someone says, please ask the doctor if a pap smear can miss to detect early, or if there's an abnormality, beg your pardon, which can be cervical cancer or lead to it. Can the pap smear fail to
most of the time we do get any abnormalities, but sometimes again it depends on how many of those cells we got. Right. So if it was not taken properly, then there is a chance that it can miss. That is why it is complementary in the sense that if you can be able to do a pap smear and an HPV, or even better, just do an HPV, because it's more sensitive in the sense that whichever number of cells that we have there, we actually go and look for what is called the DNA of the virus. So it is a lot more sensitive.
Okay. All right. Somebody says, if I had a baby before and got a cervical tear and continued with intercourse, can it cause the cancer? There's no cause effect. Okay. That because I had a cervical tear, and so I will, have cervical cancer. Right. No. We don't know anything of that sort. If that cervical tear was not repaired properly, and then perchance HPV gets onto it, then the body doesn't clear it, then there is a long-term possibility that it can lead to cancer. All right. Okay. Someone says, if one has intercourse with a cervical cancer patient, can they transmit the same to another partner?
That's an interesting question.
Yeah.
First of all, sometimes people have intercourse with ladies who have cervical cancer without their knowledge. Okay. That actually this lady has cervical cancer. Now, as we said, and I remember as we said that cervical cancer is actually caused by human papillomavirus. Right. So it is possible that, yes, you can get the human papillomavirus from there and give it to somebody else. That is why it is encouraged, if you're going to have multiple partners, then at least use something protective, which is a condom, a CD as they call it. Right. Okay. You're going to help me with this, ectropion of the cervix lead to cancer eventually? First of all, you help us with what is ectropion? Yes. Now, you remember we talked about the cervix,
right,
and the balloon, the
right,
place where we blow air into. So that is the external os of the cervix.
Okay.
Now, sometimes the cells, because you remember there is a cycle of growth and death of cells, sometimes this cell proliferate and then it leads to a reddish change on the cervix. And sometimes this reddish change during intercourse can be, the lady can have what we call postcoital bleeding. No, ectropion does not lead to cervical cancer.
Okay.
No, it doesn't.
All right. Okay. How can you test for HPV in a man? HPV or in a man? Okay. As are the ones who infect the women. Yes.
Now, HPV, because remember, HPV infection is usually contact. Okay. Skin to skin.
Okay.
Sometimes the men can also have some warts on the penis, okay, or even around the genital area. So yes, we can take some swabs from there, okay, or sometimes you can even take a biopsy from there and send it for analysis.
All right.
Yes.
So somebody else says, can the HPV vaccine be given to older women, so those who are in their 40s?
In their 40s. Yeah. Very interesting question. Research has been done on younger women. Remember, we are talking about prophylaxis before the disease happens.
Right.
Now, it is said that even women who have started having intercourse can also be vaccinated. Why? Because there is a chance, there is a small chance, but chance all the same, that even with the intercourse, they have not actually been infected by HPV. So yes, technically, they can also have the HPV vaccine.
And so if, let's say somebody has already been infected and, they got it early.
Yes.
And it was treated.
Yes.
So do they still need to get the vaccine, or what happens in such a case? Let's say maybe they went for their normal yearly pap smear.
Yes.
Detected early, like you said, stage 1.
Yeah, stage 1.
Right?
Yes.
And then it's treated and she's declared free. Does she still need to get the vaccine?
The vaccine. Now, that's a bit controversial as well, because you don't have a lot of data on that.
Okay.
But by and large, when it comes to you have been treated, what is the process or what is the management or the follow-up? So normally, once we have diagnosed that there is pre-cancer or even stage 1, and it has been treated, this lady comes every 2 to 3 months for 2 years for a checkup. And if everything is clear in those 2 years, she comes every 6 months for another 3 years, bringing it to a total of 5 years.
Yes.
If in those 5 years there is no sign of any cervical cancer, she's declared healthy, and she can continue. She can go back now to the normal every 3 years follow-ups.
Okay. And so this vaccine that you talked about, how is it done? Does it work the way you explained the kind of, you call it causative?
Causative. The things that causes.
Yes. So is it the one that you injected, then they form the antibodies?
Yes.
That's one. And then also the question about, is it just one dose, two? Yeah.
There are 2 or 3 different. There is one which is being tested right now. Okay. And that one is basically what they have done. They have taken about 9 subgroups of human papilloma virus. So it's called a nanovalent. 9 is 9, none. So it's nanovalent, and it's supposed to protect against 9 of these subgroups. Okay. We don't have it in Kenya yet.
All right.
So what we have is what we call a bivalent or a quadrivalent. In the bivalent, it basically focuses on the 2 main very virulent, subgroups of HPV, that is 16 and 18, and the quadrivalent has another 2, I think 6 and 11. Now, what WHO suggests is that these young girls should have at least 2 of these vaccines, right. Meaning, if today she had one, then after a month she has another one, then she's covered. There are some where you have, let's say today, then after a month and after 6 months. So whichever it is still protective. Right. Yes.
So then, as it's being rolled out, and we are fortunate enough, like you said, that the Ministry of Health has made it available in these hospitals.
Health centers, yes.
What has been, what is the the view, at least from us COGS, have you seen that, this is going to, in terms of the uptake of it, have you seen now that it's available, are people, and the fact that it's free?
Yes.
It's very interesting because we had the same conversation, I think, with the COVID vaccine.
Yes.
There are people who they call themselves anti-vaxxers.
That is true.
For example.
Yes.
And now this one has the double problem that it's being administered to 15 in a society that is still grappling with, do we talk to them about sex at this age? Do we do this and this?
Yes.
So what has been the uptake? Is it looking positive? Is it if you to put it on a chart, is it looking like more and more people are getting it?
According to my colleague from the Ministry of Health,
right.
Dr. Mecca, and we had a meeting, and we also had during the cervical cancer month, we also had a meeting together. Says the uptake is about 56-60%,
which is
not bad.
Okay,
but
could be better.
Could be a lot better. Okay. And again, we come back to exactly what you mentioned. No, we are in a society whereby, number one, we are not very comfortable talking to our children, even about the simple things like menstrual flow.
Right.
You, a man, talking to your daughter about menstrual flow, it's sort of, sometimes even if your wife says, can you buy me some pads? It's like, boss.
10 of the supermarket.
How will guys look at me,
right.
at the counter?
Right.
So we have a challenge with that. We have a challenge about talking about some natural things, natural processes in the body. So I think knowledge is important, very, very important, number one. Number two, age-appropriate sexual education is extremely important.
Right.
Why? Because these, our children need to know that this is what is happening to their bodies. And if they do start having intercourse without this knowledge, because they'll get this knowledge from somewhere. They'll get this knowledge from their peers, and most of the time it may be skewed knowledge all over the place. They'll get the information from the internet, and sometimes in the internet is anything and everything. So we need to sort of have a sort of an organized, structured way where this information can be passed along. And once we reach that place and say, you know what, at some point, because of your hormones, because of the changes that are taking place in your body, you may start feeling that you want to experiment or have intercourse. And if you do, these are the possible consequences.
Right.
Okay? Because once you've started, you may not end there. You may go, it may go in a completely different tangent. So we need to have these discussions. We need to have these discussions as parents, as doctors, as religious leaders, as government. We need to talk about these things, because then this knowledge will actually be imparted to them, and hopefully they'll make good use of it.
Right. So one of the biggest things that we've talked about is the cost. We've talked about the cost of some of the treatments. Somebody's asking, how much does it cost for the test? That's the pap smear, I think, and does NHIF cater for it?
Yes, a very good and very good concern. The pap smear, in the private sector may cost maybe anywhere between 1,500 to even 3,000 Kenyan shillings. In the government hospitals, it's a lot cheaper, maybe around 500-800 shillings. Now, does the NHIF cover pap smear? I'm not very sure about that. But what we are advocating as a society is that not only NHIF should cover this, but also the insurance sector. Yes. Why? Because this is preventive. And if the insurance companies, because there are some of the Kenyans who have, private medical insurance, then it will also help. You can't imagine, Willis. Some of the patients that we see are very well educated and have reasonably good jobs. But when you ask, when is the last time you had a pap smear, they will say, maybe 5 years ago, maybe it was 10 years, I can't remember, or some have never heard about what a pap smear is. Right. So that is why a forum like this, and the month that has just passed is just basically to sort of summarize, is very, very important. That please, these pap smears can be done and should be done on a regular basis, and also other partners should come on board and help actually in this rollout. Now, we can say, yes, NHIF should cater for this, and the insurance should cater for this, but what some other countries have have done, and they have eradicated cervical cancer, they have a national cervical cancer prevention program. What does that mean? It means that after collecting data, they've decided that every patient, every lady who gets to a certain age must have a pap smear. So they know where these ladies are, and they will send them information. In Kenya, we don't have that system of physical address, where you live, and they can send information to you. But again, with technology now, I mean, 90%, almost 100%, we have cell phones. We can actually send this information through cell phones. That is a possibility. But even before we go there, we need to have structures in place, because if all the women decided now, okay, the government has decided we are having cervical cancer screening, so we are coming for these pap smears, we may not have enough people to actually do the pap smears. We may not have enough histopathologists, the doctors who look and read the slides, and so on. So I think we can start slowly by developing the human resource, which is very important, by training. And we can train nurses, we can train medical officers, clinical officers, and so on. Because the pap smear does not have to be, done by a gynecologist. It can be done by other cadres. And then now, when there are issues, when there are complications, that is when now we come in as the higher cadre, as it were. So if we have this, we have a program which can actually be rolled out. And now with the devolution, there is a possibility that can be done, county-wide and so on. But we need a buy-in from all, the interested parties. And remember, we are still talking about prevention. Right.
Yes. Right. Well, of course, I see, the time is up, but I just like to ask, because there are people who still have some questions, and where can they probably get in touch with you, and even maybe even the COGS officers, or where can they get in touch with you if they have more questions and want to reach out? Yes.
Thank you very much. I am located at 5th Avenue offices, which is off Ngong Road, and the office is called Frontline Medical Consultants on the 3rd floor, 314, and the number to the receptionist is 0780 170 170. Very easy to remember. 0780 170 170. In most public hospitals, we will find a member of COGS. You find a gynecologist there, and they can also be able to help out. And we have our members actually in all the counties and even in sub-county hospitals. We wish that we would have more, because there are some places like in Nairobi, I think that is where the majority of our members are, but they are spread all over the country.
Right.
So, and we have a purpose, we have an aim of actually, as a society, to spread this information and to help our sisters, to prevent cervical cancer.
All right. So you see the number to the reception is 0780
is 170 170.
All right. So that's the number to dial if you want to book a session with the doc here, Dr. Omanwa. And of course, you can reach out to him. Like I said, also, probably, most likely, your gyna is a member of COGS.
Absolutely.
So you can also ask them about it. What I think I've also learned is what you talked about, Doc, and thank you so much for bringing that point, is about, prevention and just going to do it. The slight discomfort you feel could be of maybe 5-10 minutes.
Yeah, actually,
or less.
Even less.
Could be the thing that saves your life.
Absolutely.
So please, let's go out there, ladies, get the test, the pap smear, do it. There are different options, he said. You can do it once a year, you can do it once every 3 years, once every year for 3 years. Alafu sasa unaweza sema uko sawa kidogo urudi after 3 years, but make it part of your yearly checkup.
That would be fantastic.
That would be absolutely.
If not, at least every 3 years.
Right.
Once every 3 years. That's, for a start,
right,
as a country, as a society, that would be a step in the right direction.
All right. Thank you so much. We hope you are informed. Thanks so much for those of you who are bold enough to ask questions. I know we will not be able to cover cover all of them because of time, but like I said, you can always reach out to Doc afterwards. Asanteni sana. We will leave it there. Coming up next, if you missed the conversation earlier on in the morning, you get a chance to watch it again. Alafu baadaye, 7 na Citizen, keep it Citizen Television. Good morning.